So just to kind of give you that background. So let me go through everything. So we are Helping Hearts of California. So initially the company started in Arizona in 2008. It's still up and running. The owner, CEO, is out there running our Arizona base. They came to California in 2015. I actually just started with the company February 1st. Elizabeth has been here longer than I have, since
August of 2016.
And she actually left Riverside County, so she's a clinician there, and I left Genesis Healthcare, which is another big company. So we both kind of come from different companies because we believe in what this company is doing. So we are servicing individuals with severe and persistent mental illness. I know the new terminology is SMI, so severe mental illness. You've heard of other phrases like chronically mentally ill, co-occurring. It's always kind of changing, but it's all one and the same. Our clients are typically schizophrenic, schizoaffective, psychosis, some access to, we have a lot of borderlines, and so a little bit of everything. And so they're your clients that need to be on medication. They're the clients that have difficulty in employment. For a lot of them, this is the best that they're going to be in our type of setting, getting help. The goal is to integrate them into the community where they can maybe go to a boarding care or access services, but a lot of them have been on disability for quite some time. And even though they're stable on their medication, it's very common for them to respond to internal stimuli or to have fixed delusions. And I've had people think that they're Puff Daddy rapper. I've had people think that they're part of the mafia. I've seen it all. And this is a genuine fixed delusion. And you know, although, like I said, they're taking their medication, this is what they have been believing for a long time. And there's nothing that I can say, anybody can say, to make them think otherwise. So it's very interesting. So we have two locations. One of them is in Ontario off of Euclid. And it's kind of a downtown setting next to a bank and next to a hotel. The other location we have is in Colton. It's actually by Arrowhead Hospital, if you guys are familiar with that area. It is in a residential area. We have another site, and that's what we're actually hiring for. It's in Muscoy, if you guys have heard of Muscoy, which is not far from here. And so it is a 10-bed facility, and we are opening that facility, and we are looking to hire individuals for that. We also are going to be expanding to other places. We haven't identified them. We're thinking like Fontana, Bloomington area. And then as the company continues to grow in California, the plan is to expand to like 500 different facilities. So this week I actually have a meeting with Los Angeles County Department of Mental Health to see if they want to establish some places with us as well. So those facilities would be obviously in Los Angeles for their clients. So the whole purpose again is, you know, we're a step down. We're between an acute IMD and an augmented boarding care. IMD means Institution for Mental Diseases. The IMD that I came from is actually across the street from Patton Hospital in Highland. If you're familiar with the area, it is locked. It's 116 clients, and those clients are typically coming from Metro State Hospital, Patton, prison. They've been deemed incompetent to stand trial. It's a very, the setting, it could almost feel institutionalized, to be honest with you. We tell them when to eat, we tell them when to take their meds, we tell them when they can do community breaks. And so there are clients that maybe require that high structure, but the clients that we're targeting are the ones that don't. So yes, they have mental illness. Yes, they require medication. Yes, they require us to maybe prompt them to take that medication. But they don't require a locked setting. They're not a danger to themselves. They're not a danger to the community. They just need some help getting some sort of skills to eventually reintegrate into the community. So this is just our background. I know we kind of covered it. I used to be a social worker with San Bernardino County. Did that for a while. Went to an IMD as a program director. And so I worked with children, adults, families, and I used to work for the community crisis response team. And so we would respond in the public for clients that needed 5150s or they needed hospitalization because they wanted to kill themselves, kill someone else. And so Elizabeth, I don't know if you want to.
Well, again, my background is the licensed marriage and family therapist. I've worked with co-occurring disorders in an outpatient setting where they had the substance use as well as the mental health that played a role. I did hospital-based counseling and social work, worked every single floor in the hospital, from newborn babies to detention to emergency room, everything. And now I'm here overseeing clinical Helping Hearts.
So, you know, we got some key people working on our team, aside from us, we obviously have a lot of input from the county. We are a contract with them, so they have a lot of input on what we do, and we have a lot of meetings with them, and we're in contact, and they're there to support what we do. So they're also a part of the team in our own way. They attend our treatment teams. So social rehabilitation, we are part of the Olmstead plan, which means that in California, we want to provide the least restrictive setting for these clients that are appropriate to be in a residential treatment. So it's, long gone are the days, and I don't know, maybe it was the 80s or so, where it was like, we'll lock them up, throw away the key, put them in the state hospitals, not in my backyard mentality. And so that's kind of what people were used to doing, out of sight, out of mind. But I think as we talk about mental health and we have our awareness, people are starting to understand that everybody knows somebody with a mental illness. Everyone has had some sort of experience, and people, are starting to understand that these are not individuals that are necessarily looking to cause problems. This is an illness, the same as a medical illness. They need assistance, and who are we to just kind of say, get out of our way? And a lot of people will still think like that. I think it's our job to continue to educate them on that. But for the most part, people are starting to come around and understand that, they're a part of our community. They need our help. Not to mention, it costs about, just a little background, about almost $800 a day to have one client at a state hospital. Okay, so that's your tax dollars paying for one client. Imagine how many clients are at a state hospital for one day versus less than half of that to put them in a residential setting. So maybe there's other ways that we can spend our MHSA money. Maybe there's other ways that we can spread that out and reach more people instead of paying for state hospitals, paying for, they're in jail. We were talking yesterday with the Colton PD. We had a meeting with the chief of police, and so, you guys may not know this, but a large amount of our mentally ill are actually in jail. That is where they're at. So transitional residential, that's one of our facilities. The clients are typically there for 12 months. They're doing topic groups, they're meeting with the clinicians, they're getting support, they're having volunteer opportunities, vocational rehab, interdisciplinary team meetings once a month. They're addressing all of the discharge barriers that would prevent them from being successful if they were to live in the community. Long-term residential, those are for clients that may need a little extra help. So we're thinking like 18 months. Now these two facilities, depending on the needs of the client, we can kind of move them around and determine that maybe they need more time. So that's one of the great things about having multiple facilities, because we don't want to set anyone up for failure. When someone discharges, we want to look at the entire piece and we want to say, okay, they're ready. We're not just going to discharge them, let them end up on a park bench, or let them end up back where they started from. And I don't think we talked about conservatorship, but I guess I better.
So a great many of our clients are actually conserved. I would say like 99% of them are. And when you're conserved, what that means is you've been deemed by the court to be gravely disabled. You cannot provide for yourself. You are unable to provide food, clothing, and shelter on a regular basis for yourself. And the court has determined that since you cannot do that, they will appoint a guardian for you. Sometimes it can be a family member. Many times it's a public guardian through the county that you're in. So a lot of our people have County of San Bernardino public guardians. And a conservator is the way that you would almost think of a parent acting for a child. They will sign any kind of forms that they need. They make any kind of major decisions, which means that our clients can't elect to have surgery if they need it. That's not determined by the client, it's determined by the conservator. So it's removed a lot of the rights that just generally people have, and the conservators will make that decision for the client in their best interest. So the population that we work with, them having conservators, obviously we work closely with the conservator, and my big goal with this is, or Helping Heart's big goal with this is to have the client involved in that process. So they can advocate for themselves. They see us advocating on their behalf with their conservator, and they can kind of take up that process as we discharge them into a lower level of care. One of our main goals through our treatment here is to get them off of conservatorship so that they can kind of step up into that role in their lives and be able to manage going to doctors, making medical decisions, making legal decisions for themselves, getting a driver's license if that's what they wish to do.
And so, you know, again, for the clients that are out there, the people that are untreated mentally ill, you know, people that are off their meds, or, you know, in the community, maybe petty theft, crimes, things like that, they start to overutilize resources. And so, you know, it's not like someone who just had a bad day or a couple, maybe a ER visit, and you're on conservatorship. This is over time, the county has said, look, you've been exhausting our resources. You're in the ER pretty often, or you're getting arrested left and right. It's a buildup over time, and some of them will get off, and some of them will get back on. So unfortunately, it's a bit of a cycle, so that's where we're trying to step in and break that cycle. For an individual to get placed on conservatorship, it's $10,000. It's costing $10,000 for the court, for them to appoint them their attorney, for them to go through the process, for them to file the paperwork. So that means just for me, $10,000 to put me on conservatorship because I'm unmedicated, I'm not making good life choices for myself, and maybe I'm out there causing a few crimes. So it's a very serious issue, and I believe that San Bernardino County is doing a really good job of trying to get ahead of it and figure out how can we do the right thing for the people in the community, but also spend the money appropriately. So we are licensed. There's places that are unlicensed. Those are typically your boarding cares. You give them rent, you can live there type thing.
I have a question about your this transitional and long-term plans. So it sounds like, you know, because they're transitioning, they should be doing better, and hopefully and ideally after 18 months that they've been adequately treated enough that they can, you know, assimilate back in society. But what happens with the couple that don't meet the adequate requirements to get out?
That's a great question, so go ahead. I'll take that one.
So there are some people, we obviously will meet people where they're at. So when I meet a client, one of my jobs in assessing them is to determine, do they fit in the long term, do they need that extra time, or are they kind of past that point and they really need the transitional, they just need to solidify those skills in their life and move forward from there. If they are not going to be able to, even with the starting in long-term and then even going into transitional, it may be that they step into a board and care, which provides medication, food, and shelter for the rest of their lives. But hopefully what they would have gotten through our program is daily living skills where they're not cycling back into the hospital every other week. They can get up, they're not upsetting neighbors, community people by going in, and they have a little bit more insight, and maybe they'll never live on their own, but we've given them as much independence as possible.
And that would be their baseline.
Right.
That's success for them.
Yeah.
We have had some situations where we've tried the transitional, we've tried the long term, but as you guys know, with co-occurring, we have a lot of clients that find their old drug dealers or get into old habits and get off their meds, and I don't want to take the meds, but I'll go smoke pot. And so, you know, they get into these situations where we've had one that went back to jail. And so we try to keep the bed open for her, you know, but she wasn't ready. So, you know, Elizabeth assessed her, she spoke with her, and they'll tell you just to your face, I don't want to do it. I don't care, I don't want your help, I'm good, I want to get high. And so we have individuals like that, and we do everything we can, but you guys know that they have to be ready to make that change in their life. And so unfortunately, some of them will go back to a higher level of care. They will go back to an IMD. They will go back on conservatorship. Or in her case, she was in jail pending her court date. And so it's not a success for us. We are always kind of saddened by that because this is one more individual that we weren't able to help. But for the most part, a lot of the clients, they're tired. They're tired of this life. I miss my kids. They have kids, their parents, grandparents. They're in their 50s and they've been doing this for 20-something plus years, and they're ready. They're ready now to make a lifestyle change. So we are licensed by Title 22, and so what that means is that community care licensing comes in, they look at our facility, they say this is an appropriate place for someone to live. We have our fire alarms, we have our exits, we are clean. It's not just like a slump place, you know, just that anyone goes. So we have those standards. They come out every year and certify us. The mental health piece is by Department of Mental Health from Sacramento. They come out, they look at our topic groups, they look at our program, we submit an application, we say these are their services we're providing. These are the clinicians that are going to be here with them. This is our day program we're pretty much running in the home. And they approve it and they come out every year and do that. So we have 2 different certifications that we answer to. So a lot of standards. So this is just a diagram of the different levels of care. So again, when we talk about acute, we're thinking clients that are, you know, incompetent to stand trial. So they've been charged with a crime, but when they went to court, the judge was able to determine, like, this person doesn't even know what they've done. So they're at Patton Hospital, they're at Metro State Hospital, or some cases they're in jail waiting to get to an acute setting. Then we have the subacute, which is a locked institution for mental diseases, and that's where most of my background is at. And it's a lot of restraints, it's a lot of clients that need emergency medication, so they're so out of control that I cannot verbally de-escalate them. I cannot say, hey, come on, let's use your coping skills. They're punching someone's face in. And so we have nursing staff there, we have our medical director there, and unfortunately they require like a chemical restraint. They would require medication to help calm them down to cease their behavior. So it's a locked setting. It's pretty interesting if that's the route you want to go, but it's never a dull moment, and it is a lot of crisis work. Social rehabilitation is where we are. So we are in the community, we are a least restrictive environment, we're providing those different types of residential treatment. We are like our own day program. So we're running topic groups all day long, and that's where, some of you who want to apply for the position kind of come in. So as a behavior tech, you are running those topic groups. You are prompting them for their medication. You are providing that reassurance when those fixed delusions are kind of settling in and they feel scared. And I don't know, someone's killing me. And so you're that calm that they need to reassure them and bring them back to what's true and you're safe. So it's a lot of redirecting. It's almost like having a small child that you're repeating yourself in a very calm way. And so they really feed off of your energy and the way that you conduct yourself. And even though deep inside maybe you're a little intimidated or a little bit scared, they pick up on everything. And so it's a skill that you kind of develop over time. There's been times that I've had clients right here, like, this is it, I'm going to the ER, I'm going to punch my face in, But instead of, I can't be hysterical, I'm trying to calm this person down or evade. And so I have to just kind of tap into those skills and do my best to prevent that. Luckily it worked. Non-treatment. So non-treatment is, the room and boards, I'm not trying to bash them or anything, but some of them are unlicensed. And so, Elizabeth, a good room and board would be the one that prompts you for your meds, that do offer some assistance. But we do have other room and boards that are just kind of there for Social Security checks. And so it's not a treatment type of setting. It's a situation where a client can certainly live there, but they're not providing groups, they're not driving them to appointments. We're all inclusive, where we do all of that. So not only do we have our clinicians that meet with them once a week, we're driving them to the psych appointment. We are driving them to the dentist. We are providing those resources and teaching them. We're teaching them how to take the bus and things like that. Any questions on the levels of care? I know that's a lot of information. So these are our services, 24 hours, 7 days a week. That's where our staff comes in. That's where our behavior techs come in. So we have a staff that's awake while the clients are sleeping. They're making sure that things aren't happening that shouldn't be. They're making sure clients aren't sneaking out the house to go be with their boyfriends or whatever it is they may want to do odd hours of the night. The clients are self-administering their medications. So we do keep them locked up, but the staff is prompting them. 12 o'clock, bedtime, and so this is encouraging the client to take their medication. And it's a home-like setting. It really is. We have community dining. So the homes have been set up to accommodate 10 clients. And so the company purchases the home and then they build onto the home. So it's 2-door room, community dining. It's one of the nicer places I've been at, to be honest with you. Nice flat screen TV, making it a home that if I didn't want to live there, we certainly don't expect other people to live there. And then a lot of people say, well, this is almost too nice. What do you guys do if they break something? We fix it. Because, people, they deserve to live like that. And I do believe that if they're in an environment that's a nice, welcoming, warm environment, that they make that adjustment. They appreciate it. They kind of treat things nicely. And so in our homes, although they've been redone, they're beautiful homes, the clients don't mess with anything. One of our homes, we even have a dog. So they love that. It's kind of like pet therapy for them. They take it for a walk. They have the responsibilities. They love having our other home. We have goldfish. We're not ready for a dog yet. So we try to, again, create that home-like environment. And I'm going to do the rest. Still have their hands on.
So, like she was talking about, our staff are there 24/7, and part of what they're doing throughout the day and a little bit into the evening as well is the skill building with individual clients. We group our clients actually by threes, or 3 to 4 people in a group, depending on kind of breakdown of that, and they're with one staff, and that one staff is with them all day. They're teaching them, let's make breakfast together. how do you do this? They're teaching them, how do you use the stove? How are things organized in the refrigerator? What kind of utensils do you need in order to prepare eggs? Things like that. And it really is that hands-on, I'm doing it with you, I'm teaching you how to do it so that when I'm not here, you've learned the information. That's done on an individual level with their kind of staff leader, and then it's also done in groups. All of our topics groups, all of our structured engagement groups, what they hit is across levels. There's a very broad spectrum from this is how you turn the washer and dryer on to frustration tolerance skills of how do you manage when you get really angry at your roommate and you don't know what to do and you're in this confined space with them. You have one room and you have to share that room. So it's a wide range of skills that we're teaching, and we teach that throughout the day. We have the 4 groups a day, and then honestly the individual ongoing. We have a clinician also who does our one-on-one therapy with each of the clients, which isn't therapy in the traditional sense that many people think of therapy. I know when I became a therapist, my goal was that white couch with those wonderful people that just had a few problems. Their life was going pretty well. And they just had, maybe some mild depression or something like that. And I've never worked in that setting. Not once did my client just have one tiny little problem that was just easily fixable by my knowledge. It just didn't happen. And so the therapy that we do, we use different modalities, but mainly CBT, and she starts wherever the client starts. We have one client that really doesn't do verbal communication very well. So we've started with more tactile interventions where she gets to touch or play with things. And that just allows her comfort even in the room. We start with skill building, even in individual therapy. How can we help you get in the shower every morning and understand why you need to complete hygiene in that manner? So that's one of our, like I said, our clinician will do that. And she'll actually be hiring on master's levels clinicians to supervise through that process, and they'll be helping to run the groups and doing other individual therapy as well. So the daily self-assessment, we have the 4 groups, as I mentioned. The first one is the check-in for the day. This is part of their self-assessment. What do I want to accomplish today? What is my goal? How am I feeling right now? What's going on with me that's making me feel that way? What are the things that I need to get done versus what I want to get done? Everything like that. What do I have going on, either in my schedule that is provided by the program or in my own kind of thoughts of what's going on. I may have a family member visiting. I may have a doctor's appointment, things like that. That group is done. It's called the wrap-up group at the end of the day, and they kind of re-go through that. Did I meet what goal I wanted to meet? Did I get done what I needed to get done? Did I just get my wants list completed and I kind of left all my needs to the side? Am I feeling the same way that I did this morning? What was different? If I was feeling pretty grumpy this morning and by the end of the day I'm kind of okay, what happened throughout the day that made that change for me? So it's really looking at that self-reflection piece and trying to increase the insight. They also do the topics groups, like I mentioned, broad range, from frustration tolerance down to, we need to check the stove to make sure it's on or off. And then basic activities, we do budgeting as well, so we teach them how to create a budget, how to manage. If you owe $600 in rent, how do you buy groceries and pay utilities and transportation when you make $1,000 a month, which is a very high estimate actually for them. So budgeting is pretty difficult.
Most Social Security benefits are averaging about $800 and something a month, which isn't very much when you have to dice it in many ways and you're living in the community by yourself. So It's crucial that they learn how to even do the basic things like shopping. Some of the clients want to go to the mall. We have to educate them that maybe it's more appropriate they spend their money at Walmart or Target or affordable places, because if they blow through that check that first week, then what are they going to do?
So they are getting their checks. They don't have to, through the conservatorship.
So the conservator actually will take a portion of it and they send what they call P&I money, or personal and incidental money, and that's really the money that they're budgeting. It depends on the client. Some people get upwards of $150, but I would say the average is about $50 a month.
And that's for their cigarettes and all those expenses that they have. It's not very much.
And the rest is being saved for them for transition?
Well, some of it is spent on housing. Some of it is spent on, or saved, I'm sorry, for like, we've isolated this section for you'll need clothes at the end of the year. So we're taking $10 out of your personal and incidental money and saving it over here. Sometimes they'll get like a Christmas check, similar to that. So it really depends, honestly, the system is not very structured across the board. So it depends on the conservator you get. If your conservator thinks that clothing's really important, they're gonna take that $10 out. If your conservator doesn't have that opinion, you may get all of your personal and incidental money, but at the end of the year, you're not gonna get that chunk for clothing. So it is a difficult task under any circumstances to budget such a limited amount of money and provide a life that you wanna live. A pack of cigarettes, I think, is what, $4 now, around that? Not a smoker, so.
Yeah, maybe more, but a lot of them are. I'm kind of keep bringing that up because a lot of them kind of gave up alcohol, but they picked up smoking, and so.
And that's a huge question that I get for our facility all the time is, are we smoking facilities? And yes, we are, but we want to engage the client in understanding, every time you're smoking that cigarette, how much does it cost you? Is that what you want to spend your money on? You're saying that you also want an iPad, so which one are you balancing out more? And kind of really looking at what are the needs that you have, what are the wants that you have, and how are you going to divide your money to provide that? So, and again, our focus is to move towards that less structured, more independent. If they do go into a room and board, because it's not providing treatment, do they have the skill and ability level to say, I need to take my medication? You know what, I'm running out of food. Maybe I should go to the store. Things like that. Am I pressing this piece?
Yeah, just a second.
All right, so we do have different core areas of focus. The first one is going to be obviously the health and psychiatric. Medical needs need to be addressed, and there's a lot of you have heard the term co-occurring. That's usually referring to substance use and mental health. A lot of times too, it can be with medical diagnoses. So when you think about how a medical diagnosis might affect a mental health diagnosis, we have a lot of people that have diabetes. They're also on Zyprexa, which makes you gain weight. A lot of weight in a very short amount of time because you're just hungry all the time. That system in your body isn't working correctly, which kind of shoots your blood sugar out of control if you're eating cookies or candy or cake all the time because you're craving that. And you're gaining close to 50 or 60 pounds in maybe as little as 2 or 3 months.
Oh no, I was going to say, you find it with a lot of clients that have been taking medication for such a long period of time that they've developed these medical issues that they typically wouldn't have. And unfortunately, it's almost like what's the lesser of the two evils. Obviously, there's risk and benefits to taking their medication to treat their psychosis, but they are getting high blood pressure, like Elizabeth said, diabetes. Some of them are insulin dependent. Some of them are struggling with even anorexia. So it's like, they're anorexic, but then they need to take their psych meds, but then their psych meds make them gain weight. So a lot of underlying issues that can make it difficult for them to get that treatment. So
I've actually had quite a few people tell me that that's the reason they use meth. Because on methamphetamines, you don't eat. So taking Zyprexa isn't a problem. You're up for 3 days, you have a lot of energy, and you don't eat. And you can take your psych med. And that's their solution to that problem. Is really, when we think about how much goes into our personal appearance every day and how that affects our self-esteem and how we are in the world, a lot of those things are affected on a day-to-day basis, and we don't even kind of realize that so many of the side effects really, yes, it's better that you take the medication, it's better that you have your psychoses under control, but they are life-altering effects. We have a lot of people with the tardive dyskinesia, the muscle movements that are uncontrolled because they've been on very heavy-duty psych meds for 20, 30 years. Yes, they needed to be on those medications. Yes, it needed to be controlled. And now they're walking around in the community and have a lot of people looking at them because they can't control muscle movements because they look a little bit strange doing that. So it kind of affects everything, and when we focus on health and psychiatric, we definitely want to look at it as a holistic approach. What's affecting what? How are we managing that? Are we addressing your concern with gaining weight and taking your psych meds? How are we doing that? How are we balancing that out? A lot of it is the medication or what it's helping you with, all of those kind of things. We work with providers. We are advocates for our clients no matter what. When our client wants to change medications because they don't like the side effects, we will go and encourage them, talk to the doctor, ask these questions. When I go with the clients at any time, I tell them, there is no question you cannot ask in here. This is your doctor, and they need to understand where your mindset is and what your thought process is so that they can best help you. So we are increasing, again, with the independent living skills based on that. How do you go and talk to your doctor? How do you tolerate being in a waiting room? How do you do that mindfulness activities to lower anxiety? If you have people walking around, it's a very crowded waiting room, how do you handle that? What's going on for you internally? Are you ready to get up and just run through the glass door? Or are you able to kind of do your internal, like, calming, you can do the deep breathing, all of that stuff. The psychosocial groups, again, with the individual and group settings, but it's the topic groups, we are increasing insight. What are your personal triggers? What is it that really creates that anxiety, that anger, that fear, all of that? We're looking at what really helps you. What's the one thing that you can have that if you have that mechanism, you can actually help calm yourself down a little bit? Because that's very empowering to give them power over mental illness, which a lot of times has taken a lot of power out of their lives. So, again, with goal setting, how do we set goals? If your goal is to just never take meds again in my life, is that a really positive, well thought out goal for somebody who really struggles with schizophrenia? That may be their goal, but we want to give them the tools to set that up so that we're not setting them up for failure, and we're not giving them a lie. I've never told them you'll be off meds if you do our program. They may need to be on medication for the rest of their lives. So again, with the social skills, just based on being in a 5-bedroom house with 10 people in it, you need social skills. Everything you're doing is interacting with other people, whether you're interacting with staff, whether you're interacting with your roommate, or you're just interacting with people around your suite mates, I guess, around other people around in the facility. So we want to teach them what is appropriate boundaries. When you introduce yourself to somebody new comes into the house, how do you introduce yourself? How does that work for you? What information are you telling them? Are you saying, hi, my name is John and I have schizophrenia? What are you doing to introduce yourself? How does that look? And how are you doing that, if you're doing that in the house, how are you doing that out in the world when you meet people? Do you tell your employer what your diagnosis is? Or what medication that you think you might have forgot to take this morning?
And with the social skills, I know we take for granted that people know what's appropriate in terms of sexual behavior, but as you guys have learned, a lot of the clients that have mental illness, they may also be hypersexualized, and we do have men and women in the same home. And so it's a lot of, hey, you can't come out naked, or in a towel, or have your hand down your pants as you speak to people. Things that if they did that in a store, somebody would probably call the police on them. And so it's a lot of redirecting, it's educating them on those things that we just know because we were taught and we know what's socially appropriate, but also them getting that insight to, you know, that's not appropriate for me to proposition someone that I've just met, or whatever the case may be. And so unfortunately it's a interesting combination when you have hypersexualized individuals in a home with other individuals that maybe just got released from jail. So, you know, it's a lot of education and those social skills that we take for granted. We're not just talking about basic things, we're talking about safe sex as well. So, you know, you're an adult, you choose to engage in intercourse. These are the different types of things that can happen if you choose to do that, you know, without using a condom or with random people.
And many of the things that we've learned throughout just being us in our lifetime may not have been taught in an institutional setting where they may have been for the past 20 years. They may not be teaching those things. So it's our job to really show them what the world looks like and what the appropriate social behaviors are in all settings in the world. So, educational and vocational. So one of our main goals, like I said, is to help the person get off of conservatorship. And one of the main things that they need in order to get off of conservatorship is to prove that they have a plan of how how they're going to provide for themselves on a daily basis. A big part of that for many people is being able to go out into the world and sustain a job, or even a volunteer opportunity. Something that you go to, you get up in the morning and you do every day of your life. Whether it's going to school, some of them we help get, they haven't had the opportunity to finish high school, so we will help them to complete their GEDs. Other ones who have had the opportunity to finish high school, but really have had nothing beyond that. They had no guidance into maybe a career that they wanted or a job that they were looking for. We kind of help provide that, we're the linkage for different opportunities, whether it's working in a warehouse. I know that we are working with a lot of nonprofit organizations that help with, they get donations and we will come help and sort how those donations go out. So we're providing the workforce for these nonprofit organizations, and our clients are getting their experience out of that. They can build a resume off of that. This is now experience that they've had that they can bring to another job. Not only that, they've learned how to interact with supervisors. They've learned how to interact with coworkers. They've learned how to show up on time and in appropriate attire and dress for the job that you're doing. So if you're working in a warehouse, are you going to be, wearing a tube top? Things like that. So they're learning all of those skills, and that kind of mixes a little bit with social skills. But we really want to work on that piece with the linkage to you have skills. Let's help you, link you with places where you can use those skills.
One thing I wanted to just kind of say, again, this is Mental Health Awareness Month. I've had a lot of clients, and it affects everyone. It's not just our population that maybe had some undesirable living circumstances. I've had people in school to be an RN have a psychotic break on set about that time. I've had individuals that partied too hard in the summer, but then after that summer they were going on to play Major League Baseball. We've had people that actually had a doctorate degree getting treatment. And so again, they're in college or their onset time is like senior year or so, and their parents are attorneys and doctors and all walks of life. I guess I say that to say that it's not surprising that everybody is starting to finally listen and understand how essential these things are. But yeah, I mean, I'm always interested to find out, when did it start, how did it start, and you see it from drug-induced psychosis, you see it because of genetics, family history, all sorts of things. But again, we've had a lot of individuals that are extremely intelligent. I mean, I couldn't go to nursing school, and they were literally like in their last few classes. And this has been their experience, and now they're in a setting where people are telling them what they can and can't do. So it's always very interesting.
And that's very true. I know one of my clients actually had her master's in social work and was working through Child Protective Services with her master's, and had experienced a very severe trauma through her job, and actually that created a psychotic break for her, and she was no longer able to manage that. So it is a very real thing in every single walk of life. We work a lot with the Medi-Cal population, but it doesn't just happen in the Medi-Cal population. Or many times what happens is, if that's your sole source of income, if that's your life, and then suddenly you have that psychotic break, where do you live? You can't pay your house payment anymore. Maybe your family doesn't even know what to do. So they just kind of back off or step away. All of those things, and it does happen to everybody. So we want to, and that, I think too, with the vocation, I'm not just talking about jobs where it's more menial, but menial tasks. It really can be, we have somebody who's really good at math actually and statistics at one of our sites right now, and he really enjoys playing games that involve that. He likes the financial aspect of that. Something for him to do that would focus his brain, that would help him develop that even further. So
We know where you guys want to be done at 1. We'll try to get there.
Okay, so meal planning, shopping, budgeting is kind of self-explanatory. I've gone over it a little bit. These are just kind of day-to-day things that everybody needs to kind of really learn how to do, how much things cost, how to pick different things at the grocery store, how do you know if fruit's bad, good, and stuff like that. And this is kind of, I'm going to kind of rush through this actually. Yeah. So one of the things, I actually go out to accept them.
How do you go back to the?
Click the back arrow.
Yeah.
There you go.
So, admission criteria, we do have adults 18 and older. We don't really have an age cutoff, but they have to be ambulatory because we are not a nursing service. We don't have nurses and doctors on staff. Our main goal is to get people out in the community. So whatever medical concern is going on, it needs to be properly addressed by a primary care physician in the community. They have to have a DSM-5 or ICD-10 diagnosis. That's the main criteria for being at our facility. As Crystal said before, many of them are schizophrenia, schizoaffective, a lot of the psychotic disorders. We have a couple people that are bipolar, but that mania is very present for them, or the depression is so severe that they really are not able to complete their daily tasks. They have to have the ability to self-administer medications, which means they're taking the pills. We can show them which ones to take. We show them where to push it out. We tell them maybe what it is so that they can be reminded of how they're taking it and why they're taking it. But they have to be physically able to pick it up, put it in their mouth, and swallow the medications. Again, ambulatory, and we don't assist with like bathing or showering, things like that. We can prompt and we can give all of the tools, we can hand you towels, all of that stuff, but we do not have CNAs on staff that would assist with that.
And we do have clients that are on the injectable. We find that a lot of the clients that have a history of not complying with medication, the injectable is best for them. What that means is that they'll go every 28 days, they'll get the injection at the clinic, we'll take them, and then they're good for the rest of that time because they have a lot of paranoia with the medication. Sometimes they think we're switching them out or, you know, it hasn't worked for them. And so you're seeing a lot of the clients on that Invega Sustaina, about $2,000 for that thing once a month. So it's quite expensive, but there are clients that need that injectable. So what's the other one? It's the Invega, and we're also doing
It's respiratory construct.
yeah, so that's about another couple of grand for that one too.
Okay.
That's just something we use for the county. Again, we're contracted with San Bernardino County, so they're paying us to take care of their clients. We're in the process of expanding our contracts with other counties, so you know, Riverside, LA County, or some of our other counties that we're speaking to see if this is a service that they need. And so far, you know, what I'm getting, when I was at the IND level, the whole goal was to discharge them there, but we were backed up. My waiting list, I had clients number 45 for like a month, 2 months. There's nowhere to put them. There's not a lot of facilities, there's not a lot of places, there's not a lot of people that want to do this, and so it's very rare that you find companies that are licensed, that have that expertise, that are willing to work with this population. Again, we're kind of one of our homes is in a residential setting. Some of our neighbors aren't very welcoming. We're not out there causing havoc, we're not loud, we're not doing anything inappropriate. They just decide they don't want that in their backyard. And so there's a lot of politics that come with that as well. A lot of our staff that pull up to do their shift and the neighbors giving them dirty looks, you know. So you're going to run across a lot of people that just hold on to that stigma that people with mental illness are scary and they don't want to deal with them. So, do you guys have questions? We did ask that if any of you have your resumes and you want to kind of pass them up here, we would love to take those resumes if you're interested. We do have part-time positions. We're looking to work with, talking to Dr. Lewin about maybe creating some positions to target some students from Cal State San Bernardino. You guys are the first college that we reached out to. We're looking to get behavior techs that have that background. So, you know, either they're in the process of obtaining their bachelor's, maybe they have it. Those of you that are going to finish graduate school, Elizabeth is our head of service, and we are going to start allowing students to accrue those hours and get supervised. So 3,000 hours, I believe. So it's quite a bit of hours, but those are opportunities for you to offer therapy in a group setting as well as individual. As we expand, we're going to need more clinicians. So the company is growing. The company has a great vision. The owner is very passionate due to her own personal experiences, and she's, you know, it's awesome. She's always trying to do the right thing. And so this is a place where we want serious people that are not there to just get a check, and that's why we're kind of reaching out to you guys, but this is what they want to do. They've decided that this is the path that they want to take, and so, you know, these may be entry-level positions for you to kind of get your feet wet. That's how I started. I was actually going to Cal State San Bernardino, working direct care in a group home setting for sex offenders, and it was for me. And so that just kind of kept me on my path going.
Would this count as a possibly internship opportunity? Like, can you guys do the hours?
Is it for your graduate hours? For graduate or for
I think you're talking
bachelor's?
about for undergrad, for the internship class.
Yes.
There's the internship class is a class where they have like a contract that you have to complete with the agency, is that correct?
Yes.
I don't think I think you might be able to do that. It's a
Yeah.
10-hour-a-week commitment. The only thing you would have to check is whether or not by getting paid, whether or not that from Dr. Ward's end, is she still the internship coordinator? I think she is.
She told me she didn't have any more space. So-
For the class for this quarter. So what about spring? Is that what you're talking about, spring, or you're talking about this quarter?
We'll start in April, spring, yeah.
So starting spring, the course is closed then. So we're not talking about that issue, but in general, I don't know if you're getting paid or not, that matters. I don't think it matters. There's a contract that basically states, do you have more information about that?
It doesn't really matter if you are getting paid or not. The course is still open, but you do have to fill out the forms and get everything set up before you get that class. And I think there's only like a couple spots left. I checked last night and I was looking at it.
The big issue is for Dr. Ward is that the site is providing some kind of structured experience.
Right. And so
So
that's
that
where
would be a
Elizabeth comes
contract.
in. Yeah, so that would be, so again, it's a paid opportunity. We certainly have unpaid opportunities for those of you that are doing your MFT program or LCSW. But someone that's like a behavior tech, I mean, I think that I'm open to certainly, I'm kind of charge of the California experience out here, I'm certainly open to that. So if you're working part-time, you're gaining experience, you're getting paid to maybe pay for a couple of textbooks, and you're also getting those hours required to complete the course, I think that that's a win for everybody, and so we would be open to that. And then again, Elizabeth is really great about providing that structure. We're actually required to provide, Department of Mental Health, one of the requirements is that we continue to provide education for our staff. So 20 hours is the minimum. We're trying to do more than that. So 20 hours a year, that's the minimum that we're providing to give that continuing education, and we're doing groups on how to, and when I say groups, it's with the staff, so it's like a 1-hour training. Some of our topics are verbal de-escalation,
Safety, just around mental health in general, cultural competence, how are we working with different people that are coming in, documentation in general, how does that look, what words are we using, how are we describing behaviors, things like that. So there are a whole range of things. Medication education for the staff as well, because that's not necessarily just common knowledge, right? To just know what psych medication does what.
And so right now, with the cultural competency, you'll find that a lot of the counties, it's a requirement, and we're not just doing it because it's a requirement, it's really important that we educate ourselves on that, because things with transgender, LGBT, the communities are changing, and so in my own experience, I remember people used to say cultural competence and you would think different traditions and ethnicities, and it's not just that. There's such a broad range, and so we're really trying to target all that, because we don't want staff to look at the male walk through the door to dress and go, oh my gosh. We don't want that reaction. We want them to treat them like the individual that they are, not a big deal, this is how he chooses to dress. And guess what? He likes women. So, or likes men today. It's just, you're gonna see a lot of that. And so the goal is to not have that shock look on your face, because we provided that education, we gave you that information, and you guys know that they're free to do what they want. They're not hurting anybody, everybody's happy. I mean, this is just who they choose to be. Let them be who they want to be.
I got a question about if somebody were hired on as a behavioral tech, what kind of training do they get in the beginning?
So they go through, we actually do a orientation with them. We go through and hit all of our points of what we need them to know, the medication piece, the just kind of basic techniques. They would go through CPI training, which is nonviolent verbal de-escalation techniques, and they would get also CPR as well. So we want to get the skills kind of there at the start, and then as we would go through, they would be attending in-services. We also contract with a nurse practitioner that comes in and helps educate our people on medications, what to look for, side effects, things of that nature as well. So they would get probably about 2 to 3 days of very intensive training on those kinds of things, and then they would be shadowing for a little bit of time as well, usually around 2 to 3 weeks. Yeah, to kind of see it in person and really get that experience. Because seeing it on paper is one thing, and then seeing it in real life is very different.
Yeah, we want to invest all that time and energy, because if we give the staff the tools they need to work day in and day out, and some of them that work full-time, it's a 12-hour shift.
It is a 12-hour.
That's a long day. But some people do choose to do it because then they're off the 3 days and it works for their lifestyle. So, you know, again, we're trying to create various shifts, talking to Dr. Lewin what makes sense. Maybe even split shifts for people that have classes. You know, I've spoken to the owner and I let her know my own experiences. I said, you know, I went to Cal State San Bernardino, but sometimes classes are evenings, sometimes they're mornings. And so we're trying to come up with something that works for everybody. Now, I can't say it's going to be perfect, but certainly if there's the right candidate and we can accommodate that schedule, we want to do that, because I'd rather do that than just hire someone else that's just in it for the check and there's really no passion, no desire to learn, no tolerance to even work with the client. We've seen that, unfortunately, too, insensitivity, and this isn't the place for you. So. And in case you're curious about the rate, is that something? So the behavior tech position starting rate for those coming in, we'll say just 0 experience, minimal experience, is $12. For those of you that are coming in with education, maybe even some experience, $14.